do. So my name is Dr. Francesca Conradi. I've been working in the field of TB and HIV research for the last 20 years. And what I want to do today is to talk about the difference in presentation of TB as HIV co-infection progresses. What I'm going to be talking about this particular time is I'm going to talk about when the risk for TB disease occurs in terms of HIV progression. And at every single forum that I can possibly talk at, I'm going to stress the issue of the missing cases of tuberculosis. As Lesego mentioned, we are also going to try some little bit of new technology. So I hope most of you have got a cell phone as well, because it's quite an interesting and fun technology. And I'm going to talk about the presentation, diagnosis of treatment of TB in early HIV infection and in late HIV infection. So this is where we're going to start. This is a new technology called Slido. Well, I don't know if it's new to me. What I'd like you guys to do is to take your cell phones and to put your camera on and look at the QR code, and it's going to link you to this meeting. So if everybody can give that a go. If you can't manage, then just please let us know. But a couple of things is, first of all, I have no idea who you are, and this platform doesn't tell me. So it doesn't matter what you say. Yay, we're starting to get answers coming through. So everyone else, give it a go. What kind of healthcare professional are you? Are you a doctor, a nurse, a pharmacist, a counselor? Are you in something I haven't mentioned yet? So I'm going to give you a minute or so. There are 243 participants and we've only got a few answers. So everybody give us a go. You know how you go to restaurants, or certainly many in Joburg, and you just link onto the menu by using this QR code. So let's try and do this. Okay, we can see the answers coming through. There seem to be quite a lot of doctors who are signed on. Some nurses, a couple of pharmacists. Okay, going to give it 30 more seconds. If you can try and link in using this technology, not on the Q&A. You can also open the slido.com on a different window on your computer if you're working from a computer. And then use the hashtag 3328432 to answer. Okay, I know that it's not 100% perfect, and I see that some of you are watching on your phone, but let's just give this a go. So what we've got so far is the majority of people in the audience are in fact doctors. We've got a couple of nurses. We've got about twice as many doctors as we've got nurses, or maybe doctors are just more likely to have a cell phone to be presenting from. And then a pharmacist. We've got no counselors on, which is a bit of a pity, and no others. So I use that as an all-embracing term if we've got physiotherapists or occupational therapists or anything like that. So we've got, or also in the chat, we've got 2 doctors and a nurse and a pharmacist. So that was the first question that I wanted to ask. And this is really just a practice run. The next question that I want to ask you guys is whereabouts do you work? Do you work in the public healthcare system? Are you in private healthcare? Are you in research or academia? And or somewhere completely different from that? I'm going to link on as well, and I'll put in, I'm a researcher and an academic. So most of you guys so far are working in the public service. We've got quite a few researchers online. I'm just going to quickly give it a go too. Put my 10 cents worth in. So most of you are public health cares, a couple of private doctors, some researchers. Welcome to this talk. And as I say, this is just a practice run because I've got some real questions coming up. And I hope, we'll be able to engage a bit more. I find giving virtual lectures quite tough because I'm not sure who's out there, in fact, if anyone's actually listening. So it's great to see that. Welcome all of you public healthcare doctors, private healthcare doctors, nurses, and researchers. Okay, so we've got the first thing done. So what we're going to talk about is, when are you more likely to have an increased risk of acquiring TB disease if you've got HIV infection? And the article that I'm going to quote, and it was really interesting, when I first saw this, I was very, very surprised. It was an article published a long time ago, and it's very seldom you'll see me quoting an article published in 2005. But what they did is that they looked at a group of mine workers to decide when the risk of TB increases. We all know that advanced HIV is associated with a massive increase, but when does the risk actually start? So the way that they did this is that they looked at the database of people working in gold mines, of mainly men working in gold mines. And what they had to do as part of their medical checks is that every 2 years, miners had to go for HIV tests. And the mining industry, for all its faults, provided antiretroviral therapy much sooner than anybody else. And so they could kind of date when people were infected with HIV to a period of within 2 years. So they looked at 28,000 miners. At the time when they started this, 3,000 of them, so around 10, 12% of them were already HIV infected. They looked at the ones who were HIV negative at entry. And what they did is that they looked at their 2 yearly tests. And of that group of 2,000, 20,000, about 2,000, 3,000 of them seroconverted. And they could work out, roughly speaking, when the infection actually occurred. And this is the thing that really surprisid me. We all know that 7 or 8 years from acquiring HIV, that your chances of getting TB are very high. And if you didn't know that, then I think you're probably in the wrong forum. So we know that advanced HIV confers a huge risk of getting TB and disseminated TB. But what's really interesting is that the risk of developing TB disease starts as early as 1 year after seroconversion. So what that means is that while we're used to searching hard for TB in people with low CD4 counts, we need to bear in mind, particularly in a country like South Africa, where we've got such a high burden of TB disease, that from really early on in HIV infection, that people can develop TB disease. Whenever I look at this slide, I'm so surprised that it occurs so early on. I've presented this before, but I just want to remind people of the burden of disease that we have in South Africa, and how many cases we missed pre-COVID and how many cases I think we're missing after COVID. So this report was in fact shared with us by the South African Department of Health in 2020, well after it was actually conducted. And it was our first national TB prevalence survey, and the Department of Health funded it, and there were a whole lot of stakeholders that assisted in really trying to understand how much TB we're actually seeing in South Africa. What they did in this particular report is that they had a look at a number of households by province, and it was weighted according to the amount of population in the province. And then they screened people and had a look for active TB disease. And the way that they looked at it is if they either screened positive by a symptom test, or they screened positive because they had an abnormal chest X-ray. They then had a gene expert ultra done, or a culture test done, to see how many people actually were wandering around with TB. And the results were very surprising. In this group of 68,000 people, 234 cases of previously undetected TB were found. So these were people who had either an abnormal chest X-ray or presented with symptoms, and they went on to discover for the first time that they had tuberculosis. And the headline results of this survey really closely mimic our HIV prevalence. We know that HIV prevalence peaks between 25 and 34. Women tend to get HIV earlier, and we can see that a couple of years following that, we see a peak in TB incidence occurring. And it's so bad that roughly 1% of people between the age of 25 and 34 have TB per year. And it goes even higher for those who are above the age of 65. So we have an extraordinarily high burden of tuberculosis in this country. But something bad happened. As we all know, we were hit by a pandemic in March 2020. And we can see from this slide that the amount of TB that was diagnosed per province dropped massively. So we screened people and then suddenly we stopped finding TB. Look, there are lots of reasons for it. Maybe if you're an optimist, you think that we all wore masks, so we prevented some new TB infections. Maybe, well, certainly in some of the unexplained mortality around the surges of COVID, there were definitely likely to be some people who died of TB disease. But there's a huge drop in the amount of TB infections that we have found. And we can see that this didn't only occur in South Africa, it actually occurred in many other high burden countries, India, the Philippines, and South Africa, and Indonesia. So they're kind of countries with a similar kind of pattern to ours in terms of burden of HIV disease. The National Department of Health will soon be announcing our TB recovery plan. There are a lot of things that they've got to try and find the cases. We know that prior to the COVID pandemic, we missed about 80,000 cases of tuberculosis. What's going to happen is the Department of Health is really going to introduce a lot of testing. So just be prepared, particularly if you're working in the private sector, to go out and get a whole lot more testing of TB done, both in the HIV infected and the HIV uninfected population. Okay, so let's talk a little bit about how we find the diagnosis of TB. I beg your pardon, sorry, I went a little bit too fast. So who should we be worried about in the TB, in people who are HIV co-infected? Who should we be worried about whether they've got TB or not? I hope that when you look at the data, you can see that this can occur even if someone is only seroconverted in the last 6 months, that they've got a high risk of TB disease. And that's why we say that all people who are HIV co-infected, irrespective of their age, so whether they are 2 months old or 82 years old, whether they've got a CD4 count of 800 or 8, whether they've had previous TB or not, and whether they whatever their treatment status is, you need to screen them for TB. And this should not only be done at the initiation phase, not when you're starting the antiretroviral therapy, but should be done every single time that we encounter a patient who's HIV infected. What we need to ask all of our patients is, are you coughing? And it's not, are you coughing for 2 weeks, but are you coughing at all? Have you started coughing even yesterday? Because that is a trigger to start screening and trying to diagnose TB. Are you sweating at night? Are you losing weight? And do you have a fever? So it's a simple questionnaire. It can be administered by the receptionist, by the clerks in the hospital. And if anyone should test positive on the simple questionnaire, we know what to do. We take them out the queue, we get a Gene Expert Ultra, and we put them back in the queue for the HIV visit. So what do we do if the screening test is positive? I've told you already. We use Gene Expert Ultra now in South Africa. Ultra diagnoses almost all types of TB. So from scanty to 1+, 2+, 3+ sputum. And it also tells us whether or not they're rifampicin sensitive or resistant. The Gene Expert is almost never wrong. So if the Gene Expert is positive, then you need to start treatment. When I say it's almost never wrong, there are 2 times when it might be wrong. First of all is if there's a specimen mix-up that occurs at the level of the clinic. And we know that this can happen because you're screening 5 patients and you just mislabel one of the sputum pots. Or alternatively, if the patient has had TB, even if it's fully treated, the gene expert can remain positive for up to 2 years after the end of treatment. So when we take a previous history, if someone says, I've just finished my TB treatment, then you need to treat the gene expert positive with a little bit of caution. But if they've never had TB before, your patient has got active TB disease and they need to be initiated on therapy. Screening questions were positive and your gene expert is negative. What you can do is to give the patient antibiotics. Usually Augmentin is probably the best choice, and review within 2 weeks. Of course, we know that COVID is around and COVID can cause people to cough. So we don't want to overtreat, but we have a look and review the patients within 2 weeks. It's very useful to get a chest x-ray, and I'm well aware of the challenges of getting a chest x-ray. It sometimes means that your patients have to travel to another clinic to get the chest x-ray, but it's a useful test in the patients who we're not entirely sure whether we've screened out TB. If the Gene Expert Ultra is negative and you still think that TB is a possibility, consider sending off a culture to your laboratory. We are very privileged in South Africa. We've got 5 culture laboratories, which is more than most countries. And if you still haven't made the diagnosis, you might consider starting empiric TB treatment. And I'm hoping by the time we get to the end of this, you'll have a better idea of what to start empiric TB, when to start empiric TB treatment, and when we've run out of diagnostic options. Okay, what to do if a screening test is negative? So someone's recently presented to your HIV clinic, they just tested HIV positive, and they say, I'm not coughing, I haven't lost a gram of weight, I'm not sweating at night, I haven't got a fever. We know that starting people immediately, there are particular risk factors for not doing that. And what we need to do in this group of patients is we need to be bold and brave. We start our patients on antiretroviral therapy and at least INH, but hopefully shortly the Department of Health will begin bringing in another form of TPT. If your patient is unwell, if you know the CD4 count, then you might want to start cotrimoxazole as well and INH. Occasionally in pregnant women, we might decide to defer the initiation of IPT if they've got a really good CD4 count. And what you need to do is to follow this up at every visit to make sure that your patient hasn't developed active TB disease. So how do we treat TB? And I think that one of the things that's quite shocking to me about the treatment of TB is that it hasn't changed since I qualified. The treatment of drug-sensitive TB is exactly the same as when I qualified about 100 years ago. So we use the same drugs. The only difference that has occurred is that we now co-formulate our medicines. So we give all the medications in one pill. We tend to treat everybody exactly the same. So it's dependent on whether they're rifampicin sensitive or resistant. They're rifampicin sensitive, we use the same regimen. Obviously, patients who've got extrapulmonary TB, and we're talking about complicated extrapulmonary TB. So that's CNS TB, TB in the bone or joints, or pericardial TB, we will extend the treatment. And so there are times when we might extend the treatment, but generally it's 6 months of treatment. Most people in this country, so around 97% of people who test positive for TB will be rifampicin sensitive. So it's a pretty good, the HREZ is a good option to go ahead with. What we need to bear in mind, and guys, the TB world is moving, is that there are some patients who are rifampicin sensitive but INH monoresistant. And at the moment, we don't find them. We only find them if they haven't culture or smear converted at the end of the 2nd month of treatment. And then we will do a culture to look for INH resistance. Into therapy and taking every single dose of both the antiretrovirals and their TB treatment, they still can develop MDR. months of their treatment. There are a number of cases of patients who are sensitive to INH but resistant to rifampicin. We call those rifampicin mono-resistant patients, and we treat them according to we treat them as MDRs. I just wanted to just highlight a couple of things that have changed in the TB world. Multi-drug resistant TB has stayed the same. It's resistant to both INH and rifampicin. But the definition of pre-XDR has changed. It's resistance to at least rifampicin plus any fluoroquinolone. And XDR TB, it's no longer resistance to fluoroquinolone and injectables, but it's resistant to rifampicin, a fluoroquinolone, and either bedaquiline or linezolid. So it's much more difficult and more resistant to treatment. Yeah, just a quick Cook's tour of how we define TB and what our treatment options will be. So the treatment of drug-sensitive TB, I'm sure I'm preaching to the choir. We give 6 months of treatment. Sometimes we might decide to extend if there's been a late smear conversion. We use a co-formulated combination. It's usually called Rifa-4 in South Africa, and we give that for 2 months. And then we follow on, oh, I see a typo. We follow on with INH rifampicin for another 4 months. We know that we look at smears. We don't look at cycle thresholds to do with gene experts, but we look at smears, and we want the patient to be smear negative just before the end of the second month of treatment, and we want them to still be smear negative at the end of 6 months. Of course, the common question that comes up is, what would they if they were smear negative all the time? So those can't be called smear conversions. They can just be maintenance of a negative smear. The difficulty that we have is if there's an adverse reaction to one of the drugs. And if we look at which drugs are going to cause adverse reactions that we want to stop the medicines for, the top one is in fact pyrazinamide or PZA. PZA can cause hepatotoxicity. And if someone develops hepatotoxicity, and the definition of that is 5 times the upper limit of normal, or 3 times the upper limit of normal associated with symptoms of ALT or AST, then we would stop pyrazinamide forever. We would never revisit it. And you know, if a drug-induced liver injury or DILI occurs, that's where we'd stop. INH can also cause adverse drug reactions, again, hepatotoxicity, and sometimes peripheral neuropathy. And the challenge we have with that is, how do we get rifampicin on its own or INH on its own? And how do we take pyrazinamide out of Rifa-4? You actually can't. So we have to look at alternatives when you get an adverse drug reaction to one of the drugs. Rifampicin is our most powerful TB drug, and it is actually generally well tolerated. What do we do if someone's got INH monoresistant TB? If we make the diagnosis, which we usually don't, but if we do, then what we do is we add moxifloxacin to HREZ, and we continue that for 6 months. So there is a plan. And I'm going to just pause here for a second and talk about the new diagnostic for the diagnosis of a TB. We know that we use a Gene Expert Ultra, and that says yes or no to RIF. But just recently, the Department of Health has started to roll out the Gene Expert XDR cartridge, which strangely enough tells us about resistance to INH as well. And in times to come, everyone who tests positive for Mycobacterium tuberculosis, even if they are rifampicin sensitive, will have a reflex XDR cartridge done to make sure that they don't have INH monoresistant. Again, I always want to say at these talks, fasten your seatbelts, guys. Things are changing really quickly. So what do people complain of when we put them on to treatment for drug-sensitive TB? Something that we quite frequently forget to tell people is that their urine, saliva, and tears are going to go the same color as OROS. And it's quite alarming. And people get concerned when they see this. If we just warn people up front, and I sometimes think, you know, if our patient cries and their tears aren't colored orange, then they're probably not taking their treatment. Please don't make your patients cry, but even the tears are stained. Rifampicin can cause redness and itching of the skin, particularly in the areas that's exposed to sunlight. So while people are on treatment, tell them to wear a sun hat if they can, to get some suntan lotion to prevent the redness and itching of the skin. Most people complain of mild nausea, diarrhea, and loss of appetite while on TB treatment. What you need to do is to encourage your patients to complete their treatment, that we want them to finish it to finish all of their pills. It's only 180 days. And if they can tolerate it, and don't ignore the symptoms. If there's nausea with vomiting, then please do an ALT. Make sure you're not dealing with a drug-induced liver injury. And if necessary, prescribe a little bit of antiemetics to help settle down their GIT side effects. Many patients will get mild aches in the joints, and that's at least reportedly due to PZA. And almost all patients who are on PZA will have a raised uric acid. And again, if it's really intolerable, you can consider stopping the PZA, but prescribe a non-steroidal anti-inflammatory and pay attention to adverse drug reactions. Make sure your patients know that you've heard them and that they've got a side effect, and you want them to know that you are aware of it and you've got some treatment options for it. Some people get a bit of headache, some people get mild sleep disorders and depression. In the main, though, this is a well-tolerated regimen. And I guess that's part of the problem, is that we've got a very efficacious and well-tolerated regimen, which means that to a large extent, research into new TB medications has stopped. Well, it's been rekindled, but we haven't really moved beyond this regimen that's been used for almost 40 years now. Okay, so this is, we've been talking about the diagnosis and treatment of patients with early HIV disease. Now we're going to go back to Slido, so hang on, get your phones ready, and if you can link in on another window, do so. So a 22-year-old woman presents to the antenatal clinic. She's 24 weeks pregnant and has tested positive for HIV for the first time. She's never tested before, and this is now she's recently tested. We know epidemiologically that this patient is likely to have just seroconverted in the last 3 to 4 years. She tells you she's been coughing for 2 days. She's gaining weight with her pregnancy, so she hasn't lost weight and she's gaining weight appropriately, and she has not been sweating. Okay, so what diagnostic tests would you use in this patient? Again, what you need to do is to take a picture of the QR code, or if necessary, open Slido on another platform and use the code #3328432 and tell me what diagnostic tests you would use in this case. Would you use a Gene Expert Ultra? Would you use a smear, a culture, a urinary lamb, an IGRA, or a TST? Okay, we're getting a couple of votes for lamb. Most of you are voting for Gene Expert Ultra. Of course, I'm going to just chat a little bit more while we talk about this. Of course, we're bearing in mind that we've just probably come out of our 5th wave for COVID. So we're also aware that this could be COVID, and we would test her appropriately if we deem it to be necessary. But high on our list is we want to make sure that this patient doesn't walk out of our clinic with undiagnosed TB. I'm having a look. Yes, most of the people who are not linked to this platform are saying Gene Expert Ultra. Great, we haven't got anyone who disagrees. So I can't tell who's voting for this, but this goes through private and public sector. So even if you're a gynae working in the private sector, then you still need to be, you need to apply the following tests. And this patient shouldn't be sent for a smear. It should be sent for, she should be sent for a Gene Expert Ultra. Urinary lamb, I haven't told you about her CD4 count yet. I will in the next slide. What does an IGRA or TST tell us? It tells us whether or not she's been exposed to TB and whether she's got latent or subclinical TB infection. It's relatively interesting for prophylaxis, maybe not, but it's certainly not a diagnostic test that we use in someone who's above the age of 5 years old. I'm glad no one has voted for smear, because we don't do smears to diagnose TB. The smear can be negative even in the face of active disease, or the smear can be positive and it's not TB, it's one of the other mycobacterium that can affect the lungs. Okay. So I feel that my work is done, that everybody knows the answer of how to diagnose TB. Okay, so we sit down with this young lady and we ask her a couple more questions. Her CD, and we get the Gene Expert Ultra back within 48 hours. And that's possible, by the way, guys. Log into the laboratory systems and find out. Don't wait. And this lady comes back with a her Gene Expert Ultra that comes back Mycobacterium tuberculosis complex seen, and it's rifampicin sensitive. We happen to get her CD4 count back, and her CD4 count is 371, in keeping with her age. We know that there are exceptions, but we're okay with 371, and all the rest of her results are within normal ranges. We don't wait. We would wait for the Gene Expert Ultra, and the clinician has elected not to do a chest X-ray. I'm not sure why, whether it's because he's afraid, he or she is afraid of X-raying a pregnant woman, or whether it's logistically too difficult for him to get a chest X-ray done. But no chest X-ray was done. I just want to pause here for a bit and talk about when we can X-ray pregnant women. If we think that it's necessary, and we should treat women as if they are not pregnant. So what would our decision have been if we didn't, if she wasn't pregnant? I think as much as possible, everyone who's got TB should have a chest X-ray done to look at the extent of disease, to make sure that there's no cardiomegaly, and also if the patient's not responding, we'd like to know, have they developed new infiltrates? But this is where we're at. So, in this question, what you can do is you can answer more than one. So you can answer a couple of answers, and they tie into whether or not we should, on how long, when we start both antiretroviral therapy and HIV treatment, and TB treatment. So we can either give her standard treatment for 6 months, so 2 months of 4 drugs and 4 months of 2 drugs. And then the next question is, when do we want to start her antiretroviral therapy? Remembering that this young lady presented to our HIV clinic and she was pregnant. So we have 2 things competing against each other. I do not wish to see another baby born in South Africa who's HIV infected. So we've got to look at HIV infection as well to decide on when to start antiretroviral therapy. So we've got a couple of options. I see that the most popular is to go for standard treatment, and that's correct. We don't hold back on anything. We're not worried about the side effects of these drugs. We've used them extensively in pregnancy, and TB contributes to maternal mortality. So, and when should we start antiretroviral therapy? Well, we can start it in 2 to 8 weeks. And what's the value of that is that although she is she's 22 weeks and has a good CD4 count, what we want to do is to get her viral load to undetectable as quickly as possible. We don't want to mess around. We want to get that viral load down. So what I would suggest that we do is we start antiretroviral therapy in 2 to 8 weeks and not wait for 2 months. In 2 months' time, she's now 24 weeks pregnant. She's going to be 32 weeks pregnant, which is a little bit close to delivery time for my liking. So I would see her again in 2 weeks. If she's symptomatically better and tolerating her TB medicines, I would start antiretroviral therapy in 2 weeks. We need to keep a close eye on this lady's liver. We need to do regular ALTs because pregnancy can cause hepatotoxicity on its own. And the combination of pregnancy and TB can cause liver dysfunction. So we need to keep an eye on that. I wouldn't wait for 2 months. I'm too nervous. And I would definitely not wait until this baby is born, because that is a surefire recipe of losing both a mother and a child. If we have a look at what contributes to maternal mortality in South Africa, and it's really, really difficult to get a proper hold on what's causing women to die in pregnancy. If we have a look, we can see that HIV is a common cause of mortality, and most of those will be associated with TB. And maternal and parasitic infections, again, very non-specific terms, are pretty high on the list. I think it's a great pity that we don't really get a better hold on this, because I think it would be a good opportunity to be able to save lives of our pregnant women. Just having a quick look at the chat, and again, we're getting similar kind of things about, someone has actually said perhaps we should start ART immediately because of the pregnancy, as so long as there are no other danger signs. We're running the risks of a TB iris, and we need to be very careful about how we do that. But there is certainly no real contraindication to starting antiretroviral therapy immediately. Sorry, my slides are getting stuck. So this study was done by Neil Martinson and his group. And what they did is that they looked at HIV-infected pregnant women in South Africa. And they got a sputum test from them, and they cultured women's sputum. And what they found is that 3.3% of HIV-infected women are culture positive for TB. And what's very worrying about it is that they don't report any other symptoms. Pregnant women should be gaining weight. So weight loss is not really of that much concern. You know, if someone hasn't lost weight in pregnancy, it doesn't mean that they haven't, that their weight is okay. And coughing, you know, the report of coughing symptoms are not that common in pregnant women. This result is consistent with our TB prevalence, where we've got TB and HIV that's epidemic in this area. However, this result in pregnancy is 3 times the overall prevalence for South Africans who are not pregnant. So as we are ramping up in the TB recovery program and wanting to find more patients, we really need to be looking at our pregnant women. Untreated TB in pregnancy will cause a whole lot of complications with the baby, stillbirth, low for gestational age, premature deliveries, and much more importantly than that, can cause maternal mortality. And if you lose a mom, you lose the child. And even if the child is born, the best person to look after that baby is in fact his mother or her mother. Okay, so what we have done so far is we looked at the presentation, and I'm very pleased with the audience. I'm quite surprised that there are almost 500 of you listening, but you really seem to have grasped how to diagnose the TB, and I hope that this is going through to your clinical practice, whether you're in public or in private. Gene Expert Ultra is the way we diagnose TB, full stop. And there is no place for doing a smear to make the diagnosis. To go back to the case, let me just go back here. The reason that we're not going to do a urinary lamb on this patient is she's well. We didn't know what her CD4 count, but she certainly wasn't sick. And a CD4 count of 374, you know, it's too high to get a positive test in a urinary lamb. So it's only when we have our backs against the wall that we'd use that investigation. But a negative test doesn't tell you that the patient hasn't got TB. It means you haven't found the TB. It doesn't mean that they're not there. Okay, now we're going to go back to our conversation. Now what I want to look at is the presentation, diagnosis of treatment of TB in late HIV infection. Unfortunately, this case scenario does still occur in South Africa. And considering that we have widespread access to antiretroviral therapy and testing and a massive education campaign about HIV infection, we still see these kind of patients presenting. So a 43-year-old minor, and I've chosen this particular case, is that minors are at extraordinarily high risk for the development of TB. Presents to your clinic with a 3-month history of cough, night sweats, and weight loss. As Lesejo said, you know, this guy probably went to his GP, was given a touch of antibiotics, not investigated, might have gone to the clinic who said, shame, it's winter, here, let me give you some cough mixture. But now he's presenting to the clinic with this long 3-month history. His HIV test is positive. Again, HIV seroprevalence amongst our minors is quite high, and his CD4 count is 9. So a very, very low CD4 count. Clinically, he's got a high fever, he's got a heart rate of 120, and he is skin and bones. He's cahectic. His BMI is below 17.5. This is a picture of his X-ray. Now, the X-ray is slightly blurry. It's not the best quality, but truth to say, this is the kind of X-rays we see in our clinical practice. And in an ideal world, we would phone up the radiologist and tell them to redo it. But the truth is that we don't always have that option because it requires quite a lot of work to get the patient back to the clinic. So what are you going to do to exclude TB? Again, have a look at the QR code or log in on Slido using the code. And what are your choices? Are you going to do nothing? Because let's face it, that chest X-ray looks plus or minus normal. It's as good as we're going to get. Are we going to do a urinary lamb? Are we going to do a smear or a culture? And I'm holding my breath that nobody is going to say nothing, because then I will have failed in my duty as a treating doctor. Okay, so we've got a couple of votes. We've got a couple of votes for doing nothing because his chest X-ray is clear. Okay, so this is a patient with a clear history of coughing and weight loss. He's got advanced HIV disease. He's got a CD4 count way less than 50. Do we really think that because his chest X-ray is non-specific that we're not going to do anything? Okay, I'm going to have a quick look at the chat to see what people who are not linked into Slido are answering. So, yeah. So what I'm seeing is a combination of gene expert. Quite a lot of people are voting for a lamb as well. Gene expert, there comes another one. So we're very keen on this. So either lamb or a gene expert are the two. And in fact, in a case like this, there is certainly no harm in doing both. If your gene expert comes back negative, you really want to make a proper diagnosis of TB. So I would run both. The guy's got a number of symptoms that would put him at a risk of poor outcome of TB and HIV disease. Okay. So when we get the results back, one of the reasons that his gene expert ultra is negative is he's really battling to cough. He's skin and bone, he's really, really unwell, and he's given you as best a specimen as he can get, but nothing is really coming out. Because he couldn't get sputum, if there had been any, they would have sent for an ultra, but nobody did the smear, or the doctor looking after this case did not do the smear, but his lamb is positive. So we've made a diagnosis here. As I'm going to discuss lamb again, I'm going to talk about a couple of the pitfalls of using urinary lamb as a form of diagnosis, when it works and when it doesn't work. But it's definitely a very useful thing for us to be using in the diagnosis of TB in a high HIV prevalence area. So we know that people with advanced HIV disease, even if you look at the X-ray and see very little, but you will find lymph nodes or, heaven forbid, things like CNS complications. They often have paucity-bacillary disease, that even if they do cough, that while they might have a lot of TB bacilli living within them, they can't actually cough it up. And even if they do cough and we get them to expectorate, there are very few actual TB bacilli in them. For those of you who don't know, late diagnosis of TB leads to mortality. So this guy he's on the edge. He's skinny. He's got a very low CD4 count. If we don't make the diagnosis and start him on rapid and appropriate treatment, it's likely that he is not going to make it. So we have this new test called the TB. Well, it's not new. It's been advocated for the use in our South African population. But there are a number of caveats when we can and can't use it. My concern has always been, in the old days, we used to say the smear is negative, this patient doesn't have TB, even in the face of clear and overwhelming clinical evidence that they did. And I'm concerned that if we use LAM inappropriately, that the same thing will happen. I got my patient to pee on the stick. He peed on the stick and I didn't find anything, so he doesn't have TB. But let's talk about the guidelines for the use of LAM in South Africa. It's used for advanced HIV disease, and that's shortened to AHD, not to be mixed up with any other condition. But advanced HIV disease has a definition. It's defined as a CD4 count of less than 200. This guy's way less than 200. He's actually right down there at 50. If anyone presents with a WHO stage 3 or 4, and the stage 3 conditions, pulmonary TB is actually a stage 3 condition. We haven't made the diagnosis yet, but we know that the WHO stage 4s are the big guys, the opportunistic infections, cryptococcal meningitis, esophageal candidiasis, PJP. So any of those put your patient in the category 4, in the clinical stage 4. And then all children who are HIV positive, who are 5 years and under, they have advanced HIV disease unless they are on stable antiretroviral therapy. So these are our at-risk patients. Now, in order to save people's lives, to decrease the mortality associated with advanced HIV diseases, we need to find these patients as soon as they present to our service and to start them on appropriate therapy. I haven't mentioned the other things you would do on this patient. For example, you do a cryptococcal antigen test, and if he tests positive, we know the way that that would go. You would then consider doing an LP if you can. If not, refer or start him on treatment or prophylaxis for cryptococcal antigen disease. Cryptococcemia or cryptococcal meningitis. Out the seriously ill patients to decide for, first of all, rapid antiretroviral therapy, but in addition to that, the exclusion of TB. So the danger signs that we are looking at is people who are breathing at faster than 30 breaths per minute. And for an adult, that's very fast. You'll see them from the other side of the room. Yes, there are lots of things that will cause our HIV-infected patients to have tachypnea. COVID is one, PJP is another, simple community-acquired pneumonia, and then, of course, TB can cause tachypnea. Temperature of more than 39, yes, it can be a whole bunch of things, but this is a severely ill patient with HIV. A tachycardia, and someone who's unable to walk by himself or herself or has a low BMI, and the definition of a low BMI is less than 18.5, or are severely undernourished or wasted. Going back to the patient that I was discussing, clearly this patient fulfills at least fulfills at least one, if not two, of these criteria. So when can we use LAM? So if our patients are admitted to hospital, so in the inpatient setting, what we do is we use a lateral flow LAM to assist in the diagnosis of active TB in all HIV positive patients, irrespective of whether you think they've got TB or not. So we think someone's got TB if they're coughing, if they're sweating at nights, but irrespective of their signs and symptoms of TB, if someone is being admitted who's HIV infected, you get them to pee on a stick, or you get them to pee, and then you run a urinary LAM to decide whether this diagnosis is correct or not. And again, it doesn't matter what their CD4 count is. You've been to this training, you know that a urinary LAM can be negative in the face of overwhelming TB and a high CD4 count. And again, irrespective of any other signs of advanced HIV disease. We have no excuse in South Africa for practicing poor medicine. So even when we do a LAM, at the same time, we try to get a sputum test for a molecular diagnosis of TB. And at the moment, what we're using is a Gene Expert Ultra. And we do that because the LAM says yes or no to TB. It doesn't tell us whether someone is rifampicin resistant or sensitive. And in the outpatient setting, oops, I beg your pardon, everybody, is we can do a LAM if the patient has, if you suspect the patient has got TB. So this is someone who's not sick enough to go to hospital, but if they've got a CD4 count less than 200, or when you see a WHO stage 4. So we can use the LAM, and we should be using it at our clinic level under the correct conditions to exclude B. We don't see these kind of patients presenting. Not because I want to stigmatize them, but I'd like to be able to say, in my lifetime, we got on top of the HIV epidemic. So what are the limitations of a urinary LAM? We just say we know that the patient has got TB, and if we are betting men or women, we know that it's likely to be rifampicin sensitive. But we would still like a test to confirm that, because I can tell you for sure that someone who presents with a CD4 count of 9, if we miss the diagnosis of rifampicin resistant, that patient will not survive. So we do try to get that test, and we can do a molecular test on sputum. You can send off a TB for blood for TB culture, or you can even send off bone marrow for TB culture to try and establish which of the TB forms he's got. When you look at the test, you can have a very positive result, and it doesn't necessarily mean that he's got a lot of TB or a high bacillary burden. So it doesn't correlate, but even faintly positive. There are things that can interfere with this test, and one of them, although we don't use it that frequently in HIV-infected patients necessarily, is the use of a diuretic. So that can just dilute out the LAM antigen so that you can't see it anymore. An invalid test, so a test that doesn't have a stripe for the control, doesn't tell you positive or negative. It tells you nothing at all, and you need to repeat this test. The urinary LAM can only be done on urine. So don't think you can take a spot of blood and drop it on the test. It doesn't work. This is a urinary test only, because part of the TB bacilli is secreted in the urine, and we don't find it in the blood. So don't try and do off-label tests. Okay, so now let's just look. These are in our guidelines, but what we need to do in someone who you're thinking of doing a urinary LAM. You do normal tests. If you don't find it, you collect urine for urinary LAM. You still get as many possible specimens as you can, because this guy that I've just presented to you is likely to have quite disseminated disease. If you find a lymph node, please do a lymph node aspirate. If you're at all unsure of any CNS signs, please do a CSF. We want to make the correct diagnosis of this patient who's to survive. And then initiate TB treatment with a broad spectrum antibiotic, but please don't use any fluoroquinolones, because fluoroquinolones are one of our key drugs for the treatment of rifampicin-resistant TB. And aside from that, fluoroquinolones are not good drugs for respiratory illnesses. If you're at all worried, I adopt the notion of throw the book at the patient. So I would treat for pneumocystis carinii or pneumocystis jirovecii at the same time. And if possible, I do a chest x-ray. If the LAM is negative, then please keep looking to make sure you haven't missed a positive Gene Expert Ultra. But obviously, if it's positive, you start the patients on the treatment for rifampicin-sensitive TB, waiting for the results of the tests that will tell us whether or not the patient has rifampicin resistance or sensitivity. Why do we do this? Why are we do we have yet another test for TB? What's quite interesting in this is that the early diagnosis of TB in our really at-risk patients with low CD4 counts, if we do a LAM and we treat according to the LAM, we have seen a reduction in mortality. Before I go to my last slide, Lesejo, are you still around? Are there any questions?
Yes, I'm still around, Dr. Conradi. I do have a cluster of questions for you. So I think, yeah, let's allow maybe you can continue the presentation.
So what I'm going to do.
Okay. Poor network a bit.
The presentation, my last slide is to ask people what they felt about the presentation.
Oh,
so
okay.
Can I go ahead and answer these? Yeah.
Oh, okay. So you want us to go through some questions? Yes. Thank
Yes.
you very much, Dr. Conradi. That was very, very, very empowering, even for me, you know.
Good.
So there's a number of questions. I'll try and cluster them, especially let's start with LEM. You know, I'm going to three key things. One is that can it be used at the higher CD4 count? And why are pregnant women not included? Remember there on your advanced HIV, you said children, CD4 count, but pregnant women were not included. And someone also asked if the LEM is positive, does that mean the treatment has to be extended since this is regarded as disseminated TB? Yeah.
Why do we have so many clever people online? So to answer the last one is, why are pregnant women not considered to have advanced HIV disease? So in South Africa, people acquire their HIV infection, or women acquire the infection mainly between 14, 15 and 24 years of age. And generally when they present to antenatal clinics, they still have a good CD4 count. And we start everybody on antiretroviral therapy who test positive for HIV. And in the pregnant woman, we're doing it for two reasons. One is to save the pregnant woman's life, and the second one is to decrease mother-to-child transmission. But they are not per se at higher risk of poor outcomes for HIV. If a pregnant woman presents with a higher CD4 count, some complications of HIV, we don't want that to happen because we do not want HIV positive babies to be born. So they are not per se, many of them, most of the women who present to antenatal clinics being pregnant, they're actually in pretty good health because they're well enough to be engaging in active sexual relationships and well enough to be falling pregnant. So while there are exceptions, they are not particularly at risk for advanced HIV disease and poor outcomes.
Yeah.
Then the next question is, if the urinary LAM is positive, does this represent extrapulmonary TB and should the treatment be extended? The answer is no. So at this stage, for 6 months is enough, but we are healthcare providers. So if our patient hasn't got better at the end of the second month of treatment, we already should be thinking, why is he not getting better? Is it because we've missed resistance, or does he have overwhelming disease? Do we need to continue for longer? So positive urinary LAM does not mean that you need to treat the patient for longer. It just means that you've made the diagnosis. Does that make sense?
Yes. And then still talking to pregnant women, can you clarify the protocol then for the exposed neonate? Because you did clearly stipulate the approach for the pregnant mom, but then the neonate after birth, what then happens? Yeah.
So pretty much 2 minutes after your baby is born, the baby gets drops in his eyes, polio drops, and a BCG, isn't it?
Standard.
I mean, pretty much before they tell you if it's a boy or a girl, it's done. So the question that we've got to ask, first of all, is there any harm in that approach? So in the HIV-exposed baby with a positive we don't know when the baby is born whether this baby is HIV infected or not. If we do a rapid test on the baby, then it will be positive because the mom was positive. If we do early infant diagnosis, we can tell whether the baby was infected in utero, but we don't know in the long term whether this is an HIV infected infant. Of course, we are less worried about it if the mom's viral load was undetectable at the time of delivery.
Dr. Conradi,
And the question, so we follow a standard protocol for post or PMT-CT in this case, depending on the mom's virals are very high.
No, sorry,
are we breaking up?
Yes, I was saying maybe let's stop sharing and then you can reshare again when you want to do the last question.
Okay.
Because I think maybe it will improve the bandwidth as well. Just a little. Yeah.
Good idea.
Yeah.
Okay.
Yes.
So
yes.
Hopefully that will improve. I don't know about anyone else, but I'm so over load shedding. I'm cold and miserable, but there's nothing we can do about it.
Better already, thanks. Yeah.
So the question for the mom is, so should the baby get a BCG disease? BCG? The answer is probably not if we're unsure, particularly if the mom had a detectable viral load at the time of delivery. Then we still encourage the mom to breastfeed, and then the last thing is that breastfeed the baby if she's still got active TB disease, hopefully to wear a mask while she is breastfeeding. And then, so that's, I'm trying to cover everything because I'm not sure what the specific question was.
Yeah.
Whether it was about TB or HIV.
Yeah, it was probably about both, but also on the TB side to say, are all TB exposed infants, should they be treated for TB or should they get the prophylaxis? Or you know, how is that decision made? I don't know the current guidelines as well. I know previously we would have to do a lot of assessments and investigations. If you're confident that there's no TB, maybe give the prophylaxis, you know. But I know pediatricians, some of them do their own protocols. Yeah, let's hear.
Yeah. The first thing that we do is there is such a thing as congenital TB. So the baby is born with TB that transferred through the placenta. And those chickens, when they are born, they are unwell. They're anemic. They often have hepatosplenomegaly. They probably are small for gestational age. So when the baby arrives, we examine the baby carefully to exclude active TB disease and hepatosplenomegaly, anemia, etc. If the baby is well and thriving, we then will put the baby onto INH prophylaxis for the first 6 months of his or her life, because we want to prevent babies getting TB. And the reason we want to do that is that babies who get TB are much more likely to get disseminated disease. And if you've ever seen a case of tuberculous meningitis in a child, then it is just, it's such a terrible disease. So we would prefer to prevent that occurring. If the mom is sick, then you can, so you would put the child onto TB, onto INH. If you're at all worried, then the child needs full TB treatment.
Yeah, sounds quite complex, but I think the way you have summarized it, I think everyone, I'm sure that they've managed to get it. There was a hand from Dr. Krai Nguna. Are you able to unmute your mic, Dr. Nguna? You had a case scenario. I wanted to give you a chance.
Yes.
Yes, sir.
Yes, good evening, colleagues. Thank you for the presentation, Doc. So I'm having a challenge in one case inpatient. It's a 20-year-old female RVD non-reactive, referred from the local clinic with pulmonary TB diagnosed on a gene expect sensitive to rifampicin. So she was brought to us because she's not converting on the smear results. It's always picked up as 3 pluses of acid-fast bacilla. So we assess the patient, and then we find that they actually converted her to second a continuation phase of TB treatment with a positive smear. So we restarted the patient on Rifa-4, 3 taps according to her weight from February. So since started on that treatment, we checked the compliance during the treatment from February until now. The compliance is very good, and then still the patient is not converting to a smear negative, so we're still on a Rifa-4. So we did TB culture on sputum. It came back as Mycobacterium tuberculosis detected, sensitive to both rifampicin and INH. So we're getting worried because the patient was deteriorating clinically. You know, weight loss, persistent pyrexia above 38, tachycardia, chest X-ray shows bilateral cavitation and infiltrates. So we admitted her to the hospital just to make sure that we are not missing any other thing except for the TB. So unfortunately, our investigations, including blood cultures and stuff, are still pending. And then of note, the patient is not on any other chronic medication, so there is no drug-drug interaction going on with her. So we're just worried that the patient is clinically deteriorating. Meanwhile, is sensitive to both rifampicin and INH, and we're giving her treatment, which is we're doing a DOT with her now, but still on a repeat smear is still she's still not converting at all.
Yep.
So we really don't know what to do with her now.
So there are a couple of reasons for this, and the first one is the one that you've alluded to, that if you don't take TB treatment, you don't get better. But your patient is being DOT'd, she's on an appropriate, she's having nurse-administered treatment in hospital, she's taking it, she's not vomiting it up. So we know that she's got the drug in.
Yes.
So the other, and you've also confirmed with more than one test that this patient is rifampicin sensitive, both on culture and gene expert. So we're giving the right drug. The next potential reason for poor response is overwhelming tuberculosis disease. That the disease itself is, there's such a high bacillary load that we do see a late smear conversion, but this is very late. So I would persist. And then the last thing is that she is metabolizing her rifampicin too quickly, and she's got a low level of rifampicin. I'm not sure if it's possible to send off therapeutic drug monitoring. I don't know if you're in private or public sector, if you can send it off, but what I would do is I would increase her dose of rifampicin. So you can go as high as up to 30 milligrams per kilogram of rifampicin. So you need rifampicin on its own. And I would add 1 or 2 more tablets depending on her weight. And then, of course, you're pursuing everything else. She's HIV negative and a young woman. So it's unlikely that she's got some weird condition like PCP. Well, that's very, very unlikely. So I would think it's probably got to do with her drug levels and overwhelming disease. And in the short term, I would increase her dose of rifampicin.
Dr. Conrad, I also remember that maybe the X-ray, you know, if you have, I don't know, at the higher level, access to a radiologist to see if there's no, you know, severe disease with lung abscesses, because I know that when these abscesses are enclosed, sometimes it's difficult for the drugs, you know, to penetrate and reach, you know, this TB bacilli, you know, and then issues of malabsorption, you know. So there's a number of, I think, assessments that need to be done in addition to what Dr. Conradi has said. Yeah, Shen, you know, when you have a patient who's adherent and they're not doing well, yeah, one's heart becomes a bit sore. Yeah, but I hope that you got advice today. So I think you have to be
and in addition to that, she's in hospital, so she's not drinking too much alcohol or all the other things.
No.
So as I would say, in the short term, I just increase the dose of a rifampicin while keeping a close eye on her liver functions.
Yeah.
All right,
Okay.
Dr. Nguna, we appreciate that case. It's quite interesting and engaging. And I will share Dr. Conradi's contacts with you so that you can also engage separately so that you can get further support. I know in rural district hospitals, sometimes it's quite difficult. Yeah. Dr. Conradi,
Sorry, just before we leave this case, there are a couple of things I want to say. Do not be tempted to add another drug to the regimen. Do not add quinolone. Because then you would be adding a single drug to a failing regimen. Do not consider putting onto second-line therapy with bedaquiline and linezolid, because you have good evidence that this patient you're on the correct treatment. There's some, are you in Mpumalanga?
In Limpopo.
In Limpopo. So there's some cases that are missed by the gene expert of rifampicin sensitivity or resistance, but they come mainly from Eswatini. So I wouldn't, don't alter the treatment, just increase the dose of the rifampicin.
Okay.
Okay.
Dr. Conradi, should we consider that it might be other forms of TB and not necessarily Mycobacterium TB? I'm not sure if those would give you a sensitive result.
No,
not really.
Mycobacterium, other than tuberculosis for moths, they don't give a positive gene expert. They would give a negative gene expert. And they are usually much more resistant to our treatment. So this has been shown through gene expert and culture that this is Mycobacterium tuberculosis. And she also has no real risk factor, another mod.
Come again?
Yes, HIV negative, yes, she's HIV negative.
We even did ELISA, so it came back negative.
Yeah.
Sorry?
Yeah.
She's not immune compromised unless if she's got other conditions, you know, outside of HIV. So there's a lot of further assessments, I think, that we might need to do. Yeah. But for now, she's HIV negative, Dr. Conradi.
Yes.
Yeah. So yeah, thanks, Dr. Nguna, for that. That is quite engaging, but importantly, we need to help our client. Dr. Conradi, there was another scenario where someone said they have a patient whose gene expert result came back as trace, and then resistance was unsuccessful. So they just wanted to know then what's next from that gene expert trace. Do they treat? What do they do?
Yeah. So again, what I do is I'd look at the patient as a whole. If the patient has any symptoms of TB or an abnormal chest X-ray, I would treat, and I would treat as drug-sensitive TB. And I would also prioritize this patient for a culture. Trace can be closer, it can be negative as well. So you'd look at the patient together, but I have a very low threshold for starting in an HIV-infected individual for starting TB treatment. So if you think it's TB, start treating with Rifampicin.
Okay, cool. Now I'm gonna take you back to pregnancy and starting at the issue of iris, because there was a lot of comments after that around, why delay ART in pregnancy, but the PMTCT guidelines, the current guideline recommends that actually ARVs and TB treatment should be started at the same time, as long as those vital signs, the ones that you showed, are stable. So the patient does not have any danger signs, basically. But the question, if I was to rephrase it, is that if this is a viable way of treating TB and then monitoring patients who might complicate, why then are we not doing it for all the other patients? But yeah, let me leave it to you to share, you know, the benefits versus the risks of starting ART early. Yeah, thanks.
So the things that worry us with starting ART and TB treatment at the same time. The first one is the development of iris. Iris occurs less commonly in people with high CD4 counts. So the lower the CD4 count, the more likely you to have an iris. And iris is also really, when I say of pest value, it's not associated with mortality to a large extent. So it's kind of superstitious, and we developed this way of thinking where in the early days of HIV, when most of our patients presented with low CD4 counts.
Yes.
So, and then the next thing that concerns us is, what if you get a toxicity? So what if you get hepatotoxicity? What do I do? Which is the culprit? And again, it's a little bit of superstition, because if you do get hepatotoxicity on TB treatment, it tends to occur a little bit later. And it's kind of worrying about worrying about something that doesn't occur very commonly. So why don't we not just give DTG, Rifafor, one time, finish? I guess it hasn't been assessed in a randomized controlled clinical trial. Our controlled clinical trials really point towards early initiation, which is 2 weeks. But if your patient has, it puts a burden on a patient to have to come back. And if they understand their treatment and you tell them what the danger signs are, there's no real reason why we can't give the whole bang shoot and then give a little bit of some cotrimoxazole back to them at the same time.
Yeah, so yeah, I think because I mean we will, and I think I like your answer, because in the PMTCT program, that is the practice, and we haven't seen significant morbidity, you know, admissions or complications, you know, and it's probably because most pregnant women present at the higher CD4 count. So yeah, we will have to gain confidence and see if this is something possible for the general, you know, patients that we see on a daily basis. So yeah, that is quite appreciated. And then, yeah, I think we have went through most of the issues. Is Rifafor teratogenic? I think if it was, we would have known by now. We haven't seen a lot, but I don't know from your experience, Dr. Conradi.
As far as we know, not. But whenever we give treatment to a pregnant woman of any form, what we are doing is we are looking at the risk-benefit ratio. The risk of untreated TB is of untreated TB full stop, and untreated TB in pregnancy is mortality. So if you've got a mortality first for the mom and second for the baby. So we're looking at the benefits, and there's no doubt that leaving TB until the patient is has delivered is going to cause mortality. This is not an early pregnancy, but even in an early pregnancy, I would have no hesitation giving RHEZ to a woman. And then in pregnancy, we are also wanting to get the viral load down as quickly as possible. But, you know, we cannot leave a diagnosed TB untreated for 4 to 6 months. It's going to cause a disaster.
Yes. All right. I think I take that, and colleagues, yes, you know, let's treat TB and then manage the other things, because one of the biggest things we have really is the delayed diagnosis, is the delayed start, you know, of TB treatment, and we need to really improve in those key processes. Dr. Conradi, I've also seen this, probably the last two, because I know I will also check on the Q&A if there's more that I would have missed. But there's two things which colleagues commented on. Number one, you did mention the issue of TB diagnosis. How do I say it? TB diagnosis after TB. Yeah, I think that's what I want to say. and it was in reference with the use of gene expert. So maybe you need to give a little bit of guidance there to say, when can a gene expert be used on a previous TB infected patient? And if a gene expert is not used, what then should the clinicians use? Yes.
Yeah. Good question. So gene expert can stay positive for 2 to 4 years after an infection. And the reason that is it's looking for the TB DNA. And that can, even though TB is gone, it can still be present in the sputum. You can still find the DNA. So 2 to 4 years, you do not react to it as a positive test. So what do we do? The other thing is that most of you have seen is that people who get TB disease, they get lung damage. So they are prone to ongoing lung infections. They may have bronchiectasis or honeycomb lungs. And whenever they cough, they produce sputum and someone says this guy's got TB again. The way that we distinguish between TB disease and dead bacilli on a gene expert is by culture. And if the culture is negative, then the patient doesn't have TB. If it's positive, then they do. And again, that will also separate out the rifampicin sensitive from rifampicin resistance. If someone is really acutely ill, say 6 months after they finish their TB treatment, you will not get into trouble, in inverted commas, for starting TB treatment. But you also would have to recognize that sometimes you would have to stop it. If someone has a coincidental finding of a positive gene expert 6 months afterwards, you send that sputum for culture. And again, the value of doing a chest x-ray is you would look at the chest x-ray before they started treatment and now, and see if there's any reason to suspect that this patient has a relapse or recurrence of TB. Yes, TB can occur more than once in the same individual. It can occur more than once for a whole lot of reasons. Either they get it again because it's so prevalent in their community, or it's a relapse that it's come back. So gene expert, in summary, cannot be used to monitor response to treatment. It can only be used for the initial diagnosis. And when in doubt, send for culture.